Warm welcome to this video. The spotlight for today is head injuries in children. Very interesting and very common presentation in pediatric emergency medicine. And on a personal note, every day in my practice, I see at least 4 to 5 kids with head injuries, which makes it one of the most common injuries in children less than 15 years of age. And the incidence and prevalence varies by geographical region, but here in England, the annual incidence is around 400 to 500 head injuries per 100,000 population, and this 100,000 population is under 15 years of age. So if we take every 100,000 population who are less than 15 years of age, of that 400 to 500 they present with head injuries in a given year. Now, majority of these pediatric head injuries are minor in nature. In other words, it means that around 95 to 97% of these injuries are simple bruises, bumps, or cuts on the head. The percentage of serious injuries in pediatric age group is quite low. It's around 2 to 3%. And these are the injuries where there would be a skull fracture, or there would be intracranial lesions like intracranial hemorrhage, or it would surround around the issues of child abuse or non-accidental injuries. Now, as far as the most common cause is concerned, the most common cause still is fall, especially in children less than 5 years of age. So the common history is like kid was playing around or running or walking and tripped over something, fell down, hit the front of his head or the side of the head or the back of the head. But nevertheless, kids are playing, and sports injuries are another common cause of head injuries. So children colliding with one another, or contact sports like rugby and football. So kids can present occasionally with head injuries. So let's go on and talk about the presentations. Now, when a child comes with a head injury, now history is most obvious in most of the cases. Like they would give you a history that I was walking, I was playing, and I bumped into something, or I tripped over something, fell down and hit my head. So most commonly you would see that the condition is very obvious. They would have bruises, lumps, or bumps on the front or the back of their head, or they might have red marks, or they might have lacerations, especially kids who are playing around at home and they bump into something, like usually they trip over something and hit let's say the corner of a coffee table or something. So usually they come up with cuts and what we call as lacerations. So these are most of the common presenting features of head injuries in the pediatric age group. Nevertheless, there might be associated symptoms or complaints as well, and this can happen in fresh as well as in old injuries. And they usually, the most common complaints surrounding head injuries are headache, which might be localized or a generalized tension-like headache. Some of them they present with vomiting. Some also complain of drowsiness, a bit of temporary blurry vision, dizziness, and some complain of tiredness. So these are some of the most common presentations of head injuries. Moving on, about how to approach a child, or how do we manage these head injuries. Now, please keep it in mind, though rare, but the most important step in the management of a head injury is to rule out a serious pathology. And serious pathology here means that we have to rule out a skull fracture or intracranial lesions like an intracranial bleed. It's also important that where the history is a bit dodgy or the circumstances are not clear, there you have to consider child abuse or non-accidental injury and have to rule it out, because it's very important. Like, for example, let's say a 3 or 4 weeks old kid is brought and they say he got a head injury, and the history said that he was there on the bed or on the sofa and rolled and fell down and hit his head. So that is very suspicious, because a child who cannot cruise should obviously not bruise. So a 3 weeks or a 5-week old should not turn around and fall. So these are very, sort of a dodgy circumstances where you have to look into the details of the family, and maybe even look to see if the family is on, on social services register or something. So you have to rule out non-accidental injuries. Now, coming back, to the thing that how do we rule out skull fractures? For that, the most important modality is CT scan, because CT scan, though it's not ideal, it hasn't got ideal sensitivity and specificity, but nevertheless, it still is better than skull X-rays and other things. So that is one of the common modalities which is used to rule out skull fractures or intracranial bleeds in this case. But the question is that we do not scan everybody. As I told you that if you look at the statistics, 95 to 97% of the injuries are minor head injuries and they do not require scans. So whom to scan for that? Here in UK, the NICE, which stands for the National Institute for Clinical Excellence, they have made very beautiful guidelines, and whenever a child comes with head injury, we follow those guidelines. So if there is something which fits within those guidelines, that these are the kids who would be taken for a scan. But if a child is not fulfilling those NICE CT guidelines, then obviously we don't scan them. It's also very important that any child who comes with a head injury, after taking a history, which would be obvious in most of the cases, you have to do your physical examination, and this clinical examination should include assessment of the injury. So you should look at whether the bruise, what is the size of the bruise, whether there is a bogginess or not, if there is a laceration, how big is the laceration, where there is active bleeding or the bleeding has stopped, whether it's a gapping one or a non-gapping one. Similarly, you always shine light in both eyes. You look at the pupillary light reflex test to see that the pupils are equal in size, they are reactive to light, one is not bigger than the other one, which usually signifies a focal intracranial pathology. You also look at the you also mark them on the GCS, and this is not the adult GCS that we use, it's a pediatric GCS score that we use. And you do a relevant neurological examination, which includes looking at the gait of the child, assessing the tone and power in the muscles. So these are some of the things that can be done. I mean, it doesn't take that much time. Within 5 minutes, you can quickly do this examination, and you can reach a sort of your decision whether this child needs a scan or is just a minor head injury. Now, coming down to this NICE CT guidelines, and I want to take a few minutes to explain this to you, because this is the standard thing that we use. So every child who comes with a head injury, and after taking a history, we have to go through this guidelines to see whether they fulfill the criteria to be scanned or not. And these are very beautiful guidelines. I think they have got they are very much relevant in pediatric head injury, and they make your life very easy, because you have to go. So these NICE guidelines, which I think were revised back in 2014, they tell you what to look for and what are the red flags which actually signal that you should do a CT scan within an hour, or where you should observe a child for 4 hours, or where you should just like do nothing and give them the head injury advice, or do like if there's a laceration or something, you might have to glue it or suture it. So let's go through them one by one, and I would start with that the first one is suspicion of non-accidental injury. So any child who has got you suspect that there might be non-accidental injuries, as I told you earlier. Let's say a 3-weeker or a 5-weeker who fell down from the sofa and they say rolled up. So this is like very dodgy. Here you would be suspecting non-accidental injury. So any case where you suspect that there might be a non-accidental injury, straight away you have to scan. You have to scan the head within an hour of presentation. Those kids who had a head injury and they had a post-traumatic seizure. Now keep it in mind, these are those, you also have to keep it in mind that these kids should not have any underlying history of epilepsy, because epilepsy can be triggered by a head injury and they can have a fit after that. So if they do not have a history of epilepsy, then a seizure after the head injury, that is also an indication for an immediate CT scan within 1 hour. Then in kids who have got the GCS less than 14 on initial assessment, so when they had the injury and let's say they were attended by the paramedics and the GCS was less than 14, less than 14 means like it is not 14 but it's less than, it's 13 or below. Or the pediatric GCS score in infants less than 1 year of age, that is less than 15, it means 14 or less. So if that is the case, then again that straight away they need to be scanned. Or if after 2 hours after the injury, where the child should, most of the kids have recovered by that time, if the GCS is less than 15, 2 hours after the injury, was usually the time that they have presented to the hospital, then it has to be scanned. Or if there is a sort of a evidence of an open skull fracture, so you can see that the skull bone or the brain tissue is visible, or in smaller kids you feel like the anterior fontanelle is tense, so obviously that points that there might be a skull fracture and increase in intracranial pressure, so that needs to be scanned within 1 hour. Or there is evidence of basal skull fracture, so if somebody who's got like bilateral panda eyes or has got CSF rhinorrhea or bleeding from both or one ears, or there are like battle sign back of the mastoid, bruising and things like that where you're suspecting. basal skull fracture. So obviously these kids, they also need to be scanned within 1 hour of the head injury or within 1 hour of presentation. Somebody who's got focal neurological signs, somebody who after head injury presents with weakness of one arm or one lower limb, or facial twitching or something, you have to consider CT scan. And last but not the least, for children who are less than 1 year of age, if they've got a bump or bruise or a laceration, so you have to measure that with a measuring tape. So if it's greater than 5 centimeter, that's another indication to scan them, because obviously a 5 centimeter for a kid less than 5 years of age is quite a big one, and there are more chances that they might have underlying skull fractures or intracranial pathologies. So if any one of these few things are present, then straight away they need to be scanned within 1 hour of presentation. If none of them is present, if they're not fulfilling on any one of this thing, then it simply means they do not need an immediate CT scan. Then what we look for, we ask if there was a loss of consciousness greater than 5 minutes, and it should be a witnessed one, because in many injuries where they say, oh well, I don't know whether I passed out or not, so you never know if the child had passed out or not, or how long this episode went on. So if somebody saw that and they say, well, we timed it, it's greater than 5 minutes, that's a risk factor. So similarly, you ask about abnormal drowsiness, and this is also very tricky, because most of the kids who present usually late in the evening or something, it's time for their sleep, so they are sleeping and the parents say, oh, we are trying to keep them awake or something. Usually a child who's got to sleep, so obviously they would prefer to sleep at that. And that's not abnormal drowsiness. Abnormal drowsiness would be something which is very unusual, like a child who is normally has got a playtime, and he is prefers to sleep and is not responding to social cues and other things, not interested in the surroundings. So that would be abnormal. That would constitute an abnormal drowsiness. That's another risk factor. Somebody who had 3 or more discrete episode of vomiting. Vomiting is quite common in small kids, especially who got bumps to the back of the head, and they might throw up once or twice in quick succession. That's quite normal. It happens, especially those who also have got history of reflux as well, so they might throw up. It's just like painful condition that just simply triggers the chemoreceptor trigosome, and they just throw up. So 1 or 2 vomitings in quick succession are required. But here we are talking about discrete mean obviously they are separate episodes of vomiting, which are they've got some time intervals in between. So 3 or more, that's another risk factor. Then dangerous mechanism. So obviously somebody who was involved in a road traffic accident, or let's say pedestrian versus car, or high velocity injury, somebody threw a ball, cricket ball or a bat, and struck the child on the head, or the child has fallen from more than 3 meters height. So these are dangerous mechanisms, and obviously if dangerous mechanism is there, well, that is one of the another risk factors. And amnesia means that the child has got forgetfulness, whether it's antegrade, that means after the injury, or retrograde, before the injury. So if they do not recall the events, and that lasts for greater than 5 minutes, that is also a risk factor. But again, keep it in mind, it's usually very hard to assess that in young kids. So usually we have some we don't do it that much common if the child is a small one. We just look for the other risk factors. So if greater than 1 risk factor is present, like if just 1 is present, you don't do anything. But if greater than 1, so if these, out of these 5 things, if you have got 2 or more, what you do, you would scan them in the next 4 hours. If just 1 risk factor is present, you just observe them for 4 hours. So keep it in mind, just 1 risk factors, it is observation for 4 hours post-injury. It doesn't mean that after presentation they come to you and you have to keep them 4 hours. Like for example, the injury occurred at 12 o'clock, they came to you at 8 o'clock, and you say, oh well, we need to keep them at 12 midnight. No, it is 4 hours post-injury. So if just 1 risk factor is present. If more than 1 risk factor is present, then you have to opt in a CT, preferably in the next 1 hour, or if not, then obviously within 4 hours you need to do a CT scan. And obviously if no risk factor is present, then no imaging is required, and unless until the child is on anticoagulation. So if you see these nice CT head guides on the very discreet, these are the pediatric ones. They've got the guidelines for adults as well, which is for kids 16 and beyond. So, like obviously we do, I mean, in our practice we see up to 18 years of age, but above 16 they consider it as adults. So these guidelines are just for kids who are up to 16 years of age. So it makes your life very easy. You know who to scan and whom not to scan. But also keep it in mind that, as I told you earlier, that 1 to 2 episodes of vomiting are quite common after minor head injuries. This is very common. I see almost like 1 or 2 kids every day who had a small head, like was running and bumped into a, let's say, lamppost or something, and no loss of consciousness, nothing, but they say, oh, he threw up 1 or 2 in quick succession. Well, that happens. I mean, that's quite common in small kids. Also, some kids might have febrile illness, and I mean, this is another tricky thing because, viral illnesses are quite common in kids, and some of the kids might have fever, and because fever, they're feeling weakness, which makes them more prone to fall. So they might fall, have a head injury, minor head injury. Parents don't take it like, oh, they say, well, it was just a minor injury, don't take to hospital. But obviously, second, third, fever goes up, and with the fever they vomit, so they come to the hospital very anxious, that they think that they've probably, because they didn't bring the child earlier, he might have some serious intracranial pathology. So again, keep this in mind. The child might have a febrile illness which might be associated with it at the same time that the head injury occurred. So this is a tricky situation. Keep that in mind. It all just needs, you assess the child, the fever is there, and you look for the any evidence of infection anywhere. Look in the ears and throat, and you just tell the parents that you just give them reassurance that there's nothing serious, and with febrile illness, with paracetamol and some symptomatic treatment, the fever would go away. As the fever goes away, the vomiting and everything settles down. Also, many kids, they do suffer from like tiredness, headache, drowsiness, and which is sort of a concern for the parents. But most of the times, these are just because of mild concussion. So concussion leads to all these things, and it stays for some while, maybe 7 to 10 days, sometimes even weeks as well, and it goes away. So all they need is reassurance. Like, that's why you tell them that we go according to the NICT guidelines. If obviously these things, if you look at this criteria, they're not fulfilling the CT, so the NICT head guides, and so we don't scan them. So when we don't scan them, all we tell them, if we give them the head injury advice card, we give them a reassurance, we tell them to get symptomatic treatment, and usually goes away in a couple of days. So this was nice CT head, guys, and a bit about the CT findings. So I told you in the beginning that usually, fortunately, the incidence of but nevertheless, we do come across conditions where we have to scan them, and though most of the time the scans come negative, even like when they're fulfilling the CT head guidelines, once in a while you come across conditions where they might have fractures and intracranial pathologies. So let's go through some of the CT findings in head injuries, and you should be able to pick up these findings. So these findings are divided into fractures, extradural bleeds, subdural bleeds, and diffuse axonal injury. So we will go through them one by one. Now, fractures, and I will come to fractures later on as well. Most of the time when there's a skull fracture, it might be obvious on the CT scan. So it's usually a non-contrast CT. So you have to look at the bone window. So here, if you look at this particular image, so this is a bone window in a CT head, and you can see the bones. So obviously in kids, you would see some gaps in the skull bones, and these are because of the suture line, especially in small kids. But occasionally you have to compare it with the other side. So usually symmetrical things mean sutures, but if there's something which is asymmetrical cortical break in the skull bone, that simply means it is most probably a fracture. Like, for example, in this particular case, if you see, there is a cortical break right at this point where the arrow is. There's nothing on the other side of them. So this is most probably a fracture. So this is a bone window, and you can see there is a fracture, a cortical break in the temporal part of the skull, and this is a fracture. Also keep it in mind that many times the CT head 2D view might miss the fractures as well, and that's why I will come into later on as well. Now, the other things which are usually associated with skull fractures are extradural bleeds. Now, extradural bleeds are more common in older children, like children who are 5-6 years of age and above. It's a bit rare in younger kids because the sutures are still open. So and because of the pliability of these skull bones, um, extradural bleeds are not that much common. It's mostly the subdural bleeds which are common in younger kids. So extradural bleeds, they look like a whitish biconvex um, shadow on a CT scan. So if you look here, you can see a biconvex shadow on the right side. So there might be an associated fracture which we can't see in this particular view, but you can see a biconvex shape over here, and this biconvex because it is outside the dura. So what happens, the blood collection is there between the dura mater and the inside of the skull. So obviously it leads to a rounded sort of a accumulation of blood. So it's put pressures on the dura and the dura dips inside. So you get a biconvex dense lesion, which means it is an extradural bleed. In contrast to extradural bleed, subdural bleeds, which are more common in younger children, so obviously less than 1 year of age or less than 5 years of age, they are more common. Please keep it in mind, extradural bleed is usually because of the tear in the middle meningeal artery, branches of the middle meningeal artery, while subdural bleeds are usually caused by rupture of the fragile bridging veins beneath the what you call the arachnoid, the subdural part. So what happens, it usually leads to a lesion which you see as a sort of a concavity. So there is a concave lesion, usually unilateral. If it is present on both sides, then you have to consider non-accidental injury, because it would be very rare that somebody who bumps had one side of the head and has got bilateral subdural bleeds. So it's usually, in particular, for example, here you see that there is a biconcave lesion, whitish lesion. Whitish means it's a fresh blood, and this means it's a subdural bleed because it's beneath the dura. In the second image over here, if you see, this is an old one because it's not white, it's turned black. So black means that the blood which clotted has now resolved and it's like liquefied, and you can see bilateral biconcave density, hypodensities on both sides, and this is an old subdural bleeds, presenting now the head injury. So what caused that a few days, a few months ago? Ideally you should do an MRI. So if you do a CT scan and you get bilateral old subdural bleeds, then the next step would be to do an MRI, because MRI would tell you what is the age of the subdural bleed, and then you can actually correlate it with your history to see if there is any suspicion of non-accidental injury or child abuse or a shaken baby, etc., etc. Also keep it in mind, rarely glutaric aciduria type 1 can also present with the bilateral subdural hematoma. So that is one condition that you should keep it in mind, and that is known as glutaric aciduria type 1. So keep it in mind, not everything is child abuse. Rarely you might come across a metabolic condition known as glutaric aciduria type 1, which can give you similar type of picture. So exclude glutaric aciduria type 1. And then another feature which you might see on CT is what we call as diffuse axonal injury. So diffuse axonal injury, you don't see any bleeds. All you see is that there is loss of differentiation between white matter and gray matter because of the sudden violent movements of the skull, and usually happens in car accidents or in severe blunt trauma. So the brain is shaken, so the axons between neurons, adjacent neurons, they are just like the shearing forces just tears them off. So that leads to edema. So edema of the brain, and it can lead to increased intracranial pressure as well. But what you see in the immediate CT scan, you would be seeing that there is loss of the gray and white matter differentiation. So if that's the case, but you don't see any bleed, that is most probably diffuse axonal injury. So diffuse axonal injury, you can't do anything about that. It's usually rest, giving rest to the brain, and decreasing the metabolic rate. Again, I don't want to go into the neurosurgical intervention and the intensive care management of these things. I just wanted to tell you what you need to look for when you are reading a CT scan for a child who has had head injury. So these are some of the common CT findings in head injuries: fractures, extradural bleeds, which would be biconvex, subdural bleeds, which would be biconcave, and diffuse axonal injuries, which would show you the loss of the differentiation between gray matter and white matter on the CT scan. Now, moving on again to the fractures, I told you that in most of the cases, fracture might be easy to pick up on the CT scan, but sometimes it might be very tricky as well. Like, for example, if you look at these images, so on the left side over here, if you see, this is the 2D bone window of on the CT scan. Now, it's not showing any fracture, because you can see that there are some bilateral sort of a cortical hypodensities, which you would think that most probably in a small child would be the suture lines. But with CT scan, it's also important that if you're looking at the 2D scans and you can't pick up a fracture, request the radiologist to reconstruct it at 3D. So 3D reconstruction can give you better visualization. So here, if you see, this is the same CT scan in a 3D reconstruction. Here you can see that you can see there are two fracture lines going bilaterally, which are extending from the suture line. So you can't see it on the 2D view, but you can see it on the 3D reconstruction. Similarly, here, if you look in this lower image, again, if you look at the bone window, you can't see any cortical breaks. You can't pick up any skull fracture on the 2D window. But again, if you do the 3D reconstruction, you see that there is a fracture line, quite a big extra fracture line, which is extending into the parietal bone. It's extending from this suture line and going to the other suture line. See? So the take-home message is that if you do not pick anything on the CT scan 2D bone window, request the radiologist to reconstruct the 3D images and have a look at the 3D images, because there might be a fracture which you miss on the 2D image and you can pick it up on the 3D image. Similarly, the opposite also true. Sometimes what you would pick up as a fracture on a 2D view might not be a fracture on a 3D view. Like, for example, if you see here, there is a sort of a cortical break over here. There is no on the other side. So obviously you would take it as a fracture. But here, if you do the 3D reconstruction, you can see here, these are just the impression caused by the vessels, blood vessels. So blood vessels impinging on the bone have left some impression, which look like a fracture. So obviously this would be misdiagnosed as a fracture, but you have done a 3D reconstruction and it shows you that these are nothing. These are just like grooves which are made by the force of the blood vessels on top of the skull bones. Again, look at this image bottom here. If you look at this image, there is a cortical break right here. See, there's none over here, but there is one over here, which obviously you would diagnose as a skull fracture. But if you do the 3D reconstruction, you see it's nothing. It's an extension of the suture line. So there's slightly the suture line is extending a bit superiorly. So this is not a fracture. This is basically an extension of the suture line. So that's why it's important that when you have scanned a child for head injury and you've got the scans in front of you, not only look at the 2D bone window, but also request for 3D reconstruction, because that would lead to a decrease in false negative and false positive reports on the CT. So that's very important. That's the take home message. Okay. Now, coming to the management, how do you manage these conditions? Again, kids who have got skull fractures or who have got like intracranial bleeds, subdural or extradural, straight away they need to be blue lighted to neurosurgery. And neurosurgery, then whether even if they are treating them conservatively, they have to do it. Those kids who are obtunded, who have had like severe head injuries or the mechanism was very dangerous, they are obtunded, they can't talk to you, the GCS is low on initial presentation. Obviously, you're going to scan them, but please keep it in mind that there may also be associated C-spine injuries. So if they haven't been blocked, just put blocks, to support the neck and do a CT of the cervical spine as well, because there might be associated cervical spine injuries. Most of the times they present with bruises, bumps, lumps. Well, you don't do anything for them. If the child tolerates it well, you ask the parents to put cold compressions on that. If there are lacerations, so small lacerations can be very easily managed. If they are well opposed, you can just clean them with saline and glue them with derma bond. Or if there are large gaping one, obviously, then you can suture them as well. Similarly, most of the kids who have not been scanned, and whether you've glued their lacerations or just had bruises, they go home, you give them the head injury advice card. So remember, always give head injury advice card to these kids and document that in your notes as well. Symptomatic treatment is advised for kids who've got like headaches and tiredness and things like that. Just you can advise them paracetamol. Where you are suspecting non-accidental injury, so it's important you are scanning them, but at the same time make sure you involve a senior named pediatrician for child safeguarding, so he's there on board with you. You also involve the local safeguarding lead, usually is a nurse in most of the hospitals, so you involve them as well, and you involve the social services in such cases. And sometimes kids can have these mild symptoms after bruise or bumps to the head, like headache, dizziness, a bit of confusion. It's because of concussion. There's no point in doing CT scans for them, because CT scan is not going to show anything on for concussion. All you advise them is rest and gradual reintroduction to the activities that they were doing. So for example, if they are sports players, something, so you say you have to be assessed every now and then you gradual reintroduction into sports, and it's going to take a couple of days or a couple of weeks. So this is the most important message that needs to be given to them in case of mild concussion. Fine, so let's do two cases quickly that would give you some further insights and consolidate your knowledge which you have learned so far. So let's start with the first case, which is a 5-month-old infant arrives at the emergency department. He's strapped to the sort of a board with, let's say, it's got a cervical collar in place as well, or the blocks. And the history is that the father was holding him in his lap in the front passenger seat of their vehicle. When the driver lost control, the car crashed into a tree and the child was ejected from the car through the windshield. So he came out of the windshield. This is very dangerous mechanism. So the paramedics arrived on the scene. They noticed that his GCS was quite low. It was 6. So they intubated him at scene. He had a seizure as well, self-lasting seizure, and for 2 minutes, and then he was brought to the hospital. So obviously you are examining him. The mechanism is very dangerous, low GCS, he's tachycardic, hasn't got any evidence of fractures anywhere on the body. Rest of the examination is benign. You can't see anything on the extremities, but he's got facial and scalp lacerations, and his anterior fontanelle is bulging. Suture seems to be slightly separated, and you do a fundoscopic examination which shows bilateral retinal hemorrhages. So obviously he is fulfilling the NICE CT head guidelines criteria. So what is the most likely etiology for this child's mental status? Obviously you're going to scan them, but a child of this age, 5 months of age, who has got tense fontanelle, who's got gapping sutures, simply mean increase intracranial pressure. So there is likely a skull fracture somewhere, obviously, because the mechanism was also very dangerous. But his altered mental status is most obvious because of increase in intracranial pressure, and this increase in intracranial pressure is most probably caused by what? It would be subdural bleed. I told you earlier that in small kids it's usually subdural bleeds. In older children it's usually extradural bleed. So the most likely etiology here would be subdural bleeding. Obviously you need to confirm it through the CT scans. Then again, what is the most appropriate study? CT scan. So we always start with non-contrast CT. Question number 2, you are the team physician for a high school rugby team, and during the first quarter of a game, you watch that the quarterback has got a head-to-head tackle with another player, and so they bump their head into one another, and after that he falls on the ground and he does not get up. So you just rush and see how he's doing. So you find that he's breathing, he's got a steady pulse, but he's unconscious, he's flat on the surface while you are evaluating him. So he just wakes up. Now after waking, he just remembers his name, but he can't remember what is the day, so what is position in the team, or what is he doing there on the ground. So he has lost his memory for some time. Now he hasn't got any sensory or motor deficit, so he can move his hands fully. I mean, he can look here and there. The only thing is he's confused. He doesn't know what has happened. But so you take him to the side, and then after 15 minutes, he is fully oriented. He gets his memory back, and now he remembers what had happened, and he wants to go back to the sport. But the coach says, "Oh no, you had a head injury, so you won't be allowed to go back." The player appeals to you. They say, "No, I want to go back and play." So, what is the most appropriate management as a doctor? What advice would you give? So, this is an interesting case because this child had a head injury. Let's say their head collided with one another in the game. He lost consciousness for some time, but then he woke up. Probably that was less than 5 minutes. He woke up. It's got temporary amnesia, which resolves within 15 minutes. So, and he has got any motor deficits. His pupils were equal and reactive to light. He didn't vomit. He hadn't had any fits. So again, he is not fulfilling the criteria for a CT scan. But this, the episode of passing out and then forgetfulness for some time, and maybe later on he might have headaches and some confusion as well. This fits the bill for concussion, mild brain concussion. So mild brain concussion, as a doctor, what advice would you give them? You would tell them that you stay off the sports and there should be a gradual return to the sport. It's not like tomorrow, day after tomorrow, you have to go back slowly and gradually, because the American Academy of Pediatric guidelines, they say that there should be a graded return back to the sports, and at every grade they should be examined, and they should be given this advice that they should have to be slow and steady. So it shouldn't be like they should take rest for 4 or 5 days and they're back into. So slowly and gradually. So let's say he starts with a bit of running and then a bit of like sports he plays for 10-15 minutes, and then so on and so forth. Within a couple of weeks he is fully back into his game, but not in one go. And these are the American Academy of Pediatric guidelines for concussion injuries. So keep it in mind. Kids who have got concussion, you tell them that there would be some confusion, there would be some memory loss, there might be some personality changes as well, but it will go away in a couple of days. So they don't have to freak out. They have to take it easy. If they've got headache, you can give them symptomatic treatment, but they should stay off their activities like which requires a lot of physical or mental concentration, and there should be a graded return, because that's the most successful thing, graded return, and this is what the guidelines they also recommend. So I hope you have understood this very interesting topic of pediatric head injuries. Before going, again, those of you who have not subscribed to my channel, subscribe would be fantastic, and if you like my lectures, a thumbs up would be great. Share my videos with your friends. Please do comment, and if you got a question, you also put it down in the comment section below, and I will get back to you as soon as possible. So have a very good day. Bye bye.